Our speaker this morning is Dr. Felecia S. Waddleton-Willis, D.O. Dr. Waddleton-Willis is a graduate of Philadelphia College of Osteopathic Medicine. She currently serves as adult and family medicine physician at Mid-Atlantic Permanente in Columbia, Maryland. A pioneer of osteopathic medicine, the first African-American clinical provider in Longview, Texas, Waddleton-Willis was recruited to open and manage a private family medicine clinic for an underserved population in transition. She has valued the acknowledgement of the social, familial, cultural, and economic dynamics that so often impact health and wellness. And this is in little print. And my eyes are having a little problem, so bear with me. Where was I? That's better. There she, wait a minute. While working for the state of Washington Department of Early Learning, she was appointed an inaugural council member for the Governor's Interagency Council on Health Disparities. There she pursued a passion for exploring the education and cultural aspects of social determinants of health and their impact on health and wellness. In the first quarter of 2024, Dr. Waddleton-Willis received the historically highest MPS, that's mean physician satisfaction score, in the adult medicine and primary care department of the Baltimore region.
Wow.
Dr. Waddleton-Willis is recognized as recipient of the Baltimore Service Area Most Improved in Quality Performance Mid-Atlantic Permanente. She is named in the 2016 the Bethesda Magazine's Most Dedicated Physicians. Our very own Dr. Felecia Waddleton-Willis.
Thank you so much for everybody coming. Thank you for the committee. Thanks to Bernice and Dr. Smith for inviting me. Hopefully you can hear me in the back. Okay, all right, great. So one of my favorite topics is to present about what it is that I do for a living. I am a physician, I am a DO. And so as I move through the slides, I may interchange the word DO or osteopathic physician so that you will understand that they're basically one and the same. I am a physician, and so I'll give you some points of information. I'm also going to share with you some context. I am a Bible study student. I see a Bible study person in the back that I know very well. And with Bible study, we always have to look at what is the context. Even though I'm going to give you information about manipulation and whatnot, in the first few minutes, the context of what it is that brought about osteopathic medicine. So try to bear with me. So what is a DO? In my slide deck, I have a lot of different didactic and educational things, but this is one of the areas that I'm very proud of, and it happens to be when I was awarded in 2020 the fellow, the name fellow basically meaning that I had the highest, one of the highest recognitions in the field of family medicine. So this is my classmates in 2020. So the osteopathic philosophy deals with 4 components. Our founder is Dr. A.T. Still, and Dr. A.T. Still is the son, or was the son, of a Methodist minister. So why did I even buy into that? You know, I mean, of course I could have selected a different field of practice, but the osteopathic practice dealt with his tenets and his principles. His father was a part of a team of ministers, as I said before, and because it was during the time of slavery in 1844, that particular denomination, of course, split. And it just so happened that with that split, there were the persons who were fearing and looking at slavery as their priority, and then there were the persons that actually had the abolitionist practices. And so his father sided with those persons who were looking at the abolitionist team. And with that, he decided that he would go further into communities and use these types of principles dealing with the spirit. He actually mentions in his studies about the spirit, how the body moves, how we breathe, how we actually use our spine, our musculoskeletal system, and how it is that we receive healing. It is historically factual that in the osteopathic practice, especially early on, many of the practice types are where persons or physicians are going into communities that are small and underserved. Communities, especially that are even less than 1,000, is how it actually started, and even today. So this brings us to the principles of osteopathic medicine. Number one, the body operates as a unit, the mind, body, and spirit. The body is capable of self-regulation, maintenance, and healing, and the body's structure and function are reciprocally interrelated. The rationale for treatment is based on the relationship between these. And so what I found was we develop a system of medical care for our patients. How it is that we are able to promote the innate body's ability to heal itself. We look at the lifestyle and the wellness principles that the patient already has and look at their community connections. This is what we're taught from day one. We're not looking at this later on in internship and residency. We are part of the system of healthcare that focuses on this particular fact, these particular principles. And then, of course, we look at the barriers to medicine and we try to break those down. We are the originators of those persons who practice and look at disparate communities, because A.T. Still went into these smaller communities in Missouri and in Kansas. He specifically looked at Native populations, persons who at later on times were coming out of slavery, because this was 1898 when his first school was invented or was started. This was well after, but there was still some thought about how do we actually heal the body. There was some disconcerting thoughts about health and healing. Do we look specifically at pharmaceuticals only? And this was something that he questioned. He looked at those populations who were dying of pneumonia, of typhoid, of cholera, and then he incorporated principles looking at how the body was behaving once the person became ill, and what we call lesions, which I'll get into a little bit later. So here are some of the things that we are dealing with today. 41 schools of osteopathic medicine. And then there are affiliate schools. I went to the Philadelphia College of Osteopathic Medicine in Pennsylvania, and my school actually has an affiliate school in Georgia, and many of them do. So this is A.T. Still, and let me also say the word osteopathic, it's kind of a misnomer. If I could go back and talk to A.T. Still, I would probably say maybe we should name it something a little different, because everyone thinks, okay, are you a bone healer? Are you a bone specialist? Do you do surgery? Well, in fact, those of us who practice osteopathic medicine, even though we are taught about how the manipulative therapy helps us to diagnose, and we are taught about ways that we can actually diagnose using the musculoskeletal system, we are not bone specialists, but we are fully comprehensive physicians like anyone else. So in our training, those of us can become family physicians like I did. I did not want to specialize, so to speak. Those of us who can become surgeons, cardiologists, and you may know someone, or you may have a person that you go to who is a DO, and what I call an undercover DO. I am not an undercover DO. I spread my osteopathy very, very openly, and my patients know. They might not know technically what it is that I'm doing, and my staff knows. When I close that door, and if it's appropriate for me to do manipulative therapy to treat you, it doesn't mean that you have to go out and tell everybody and then everybody comes to me. I have my panel that's set, but I really want patients to reap the benefit of what it is that I've learned to do. So this, just in brief, is the evolution of osteopathic medicine. I won't go into it in detail, but again, what I was saying earlier, there were questions about whether or not the healing properties or processes of healing were only limited to pharmaceuticals and these traditional methods of treatment. And then the contributions of the germ theory that we all are pretty familiar with. Just reminding you that right before all of this, there was not even the practice of washing hands, not even the practice of using a mask, using gloves. People were having surgical procedures. They were dying because of the germs that were present. A.T. Still said something is wrong with this, and he addressed some of those principles. So today, we as osteopathic physicians are able to practice in all 50 states. All 50 states. So there is not a restriction. We have full licensure, and we go into internship, residency. Certification is required, just like any other practicing person. I chose to go beyond certification, and as Bernice shared with me, I also completed a couple of fellowships, health policy fellowship, as well as becoming a fellow. And this is another reminder, we are not alternative physicians. We're not alternative practitioners. We are comprehensive physicians. So, getting into the areas of manipulative therapy. So there are a number of areas that are listed here. What I will talk about are each of them in brief. And I also want to mention that if you are curious about why I went into osteopathic medicine specifically, there is a video on YouTube, and you could also go to that site. At the very end of my presentation, I also will share with you a small video from my parent association, which is the American Osteopathic Association. So, manipulative therapy, what does it really mean? It basically means that, number one, day one of medical school, no matter which medical school of osteopathic medicine each of us has trained in, we are given 200 additional credits of principles and practice. So in addition to all of the other didactic lessons that we are expected to learn, we're given these as extra. We're partnered with each other, and then we also have a patient that we're assigned to. We're assigned to patients in the hospital, and we learn the principles that A.T. Still has brought forward, and we actually use our hands to either diagnose, to treat, or to do both. So this is the first. High velocity, low amplitude is what HVLA stands for. Many of you may have heard, or many of you may have actually been to a chiropractor. This is the area where there is a little bit of an alignment between our practice and the chiropractic. Actually, chiropractic historically came out of the osteopathic tradition. Chiropractors do not prescribe medicines, or they do not practice in pharmacology. We incorporated that. A.T. Still gave over to that, and now we are fully practitioners with everything that's included. But the high velocity is a component you're probably familiar with. It is when we take a muscle or a tissue area at the level of the joint, and we take it to what we call the barrier of movement, and we are able to correct that resistance. This is what some people are a little fearful of it, and we hear a person saying, "Would you just pop my neck?" Well, it's neck, it's spine, it's low back, wherever it is, it does have an obvious movement component, high velocity, and it's quick. Muscle energy is where the practitioner uses his or her own muscle strength, taking it to the barrier of movement, and the person engages against that person's strength. So if you look at a person who's using, say, the biceps muscle this way, and the biceps muscle might not move beyond this engagement, then the practitioner may, using the muscle energy technique, take it to that limit and say, push against me. And in doing so, in different regions of movement, one can accomplish full range of motion. So muscle energy is different than high velocity. High velocity is all practitioner, but the muscle energy technique uses the patient as a participant with that particular technique. You follow me so far? Yeah. Okay. This one's very difficult to describe. This one is one of my favorites because it's so challenging. When I get into the room with the patient and I tell them I'm going to take off kind of my cognitive hat and I'm going to put on kind of my sensory hat, because I have trained my dexterity, my fingers, to detect very, very, very minute areas of what we call lesions or problems. And the craniosacral therapy involves the cranium, which is the head, the bones. There are bones connected to muscles and tissue that move where the body is moving, whether it's breathing in and out or if there is resistance to movement. But when you're using craniosacral therapy, you must align what's going on with the cranium with the sacrum. And the sacrum is this pie-shaped bone back here. So a reasonable way to use craniosacral therapy is if someone has headache, if someone has maybe had some problems with vertigo. Craniosacral therapy is very subtle. One way I think about it visually is, if you've ever seen a fish and the gills move, and the fish is living in the the water, but the gills are moving really subtly. This is what theoretically I'm feeling when I put my hands on the person's cranium. So the very areas on the top of the head, on the side, and also in the back, they actually move with the muscle and with the breath. People don't think about it, but it really has movement. So if you're using craniosacral therapy, you have to use the cranium, and then you have to also correct what's going on with the spine at the base where the sacrum is. Very, very subtle. And strain, counter strain. This is the one where a person may think of trigger point. You might have, an area on your back, and you're like, it just hurts right in that one spot. Well, this particular technique, this strain, counter strain, allows kind of a squishy feeling underneath the fingertip to be able to correct. And again, it's very subtle. We're trained in it. I'm very well trained in it. And you can have several strain, counter strain areas within a collection of one muscle tissue area. This is all what we call tissue texture changes. When we learn in medical school to do manipulative therapy, we use an acronym, and I'll share one of my secrets about this. So the acronym is called TART, T-A-R-T. So what we're feeling for, T is tissue texture, A is asymmetry, is the area same on one side or different on the other side. We look for this when we have a person to stand, sit down, lie down, whatever it is. T-A-R. R is resistance. Is the tissue moving against me? And then, of course, the last T is tenderness. Does it hurt? Where does it hurt? What kind of hurt is it? And of course, if we look at my allopathic or MD colleagues, it's not unlike what they're looking at, but we're in depth in looking at this. Everybody is asked, what does it feel like? Why does it hurt? Is it burning? You know, what kind of pain? But we go deeper. And this is what we're talking about in these techniques. This is my favorite. So, this is a picture. It's an anatomical picture. Yes, I do love science. I like the body. But this particular picture, when I discovered it as a internet photo, I was blown away because I've been through the medical training, and then of course I've also gone to additional training for this last technique which emphasizes this photo. This is pronounced fascia, and you can see evidence of fascia all over the internet. Fascia is a connective tissue property. This is what it is. It's anatomical. So if anyone has ever had knee surgery, think about your arthroscopic surgery, where we're going inside a joint space and you're looking at this kind of wispy area that is what the arthroscopic surgeon has to kind of move away to get to the joint. Or think about when you are having a meal with some meat. So you're having chicken, and you're cutting away at the area that's kind of rubbery. That area that we usually don't eat. We eat the meat, we don't eat the bone, but there's a rubbery area that's connected. That is fascia. That's connective tissue. And when I discovered and relearned, in an anatomy class, we learn about it, but then they move away from it. But in osteopathic traditions, we don't move away from it. It is living, breathing. It encompasses the blood flow in a very minute way, as well as nerve endings. This very anatomical structure has a pain mechanism. It's minute. But if you look really closely, this slide doesn't project it very well, but right where the wispy area, you can see a little redness, red haze. That's blood. And that is an area where a person may develop pain, but they can't really explain why they have pain there. It's like, okay, but it hurts here, but it hurts here, it hurts here. Because fascia is connected from the entire part of the body, from the base of the skull to the shoulders, to the elbow, to the hips, to the knees, all the way down to the base of your heel. And inside, it moves internally, in between all of the tissue areas. So because of that, if you injure it, and you've done everything else that you can think of, and it still hurts, and it's like it hurts here, it hurts there, when I do this, and you can't describe it, it may be fascia. So, myofascial release. Again, think about the picture of the fascia. And this is the one where people will say, I went to a massage therapist, and I think maybe you're going to do massage too. And we are somewhat kneading the tissue, but it's really not massage. It is myofascial release. If you go to a massage therapist and they say, I do deep tissue massage, this is probably myofascial release. So I mentioned earlier that this was one of my favorites because I trained in extra additional treatment methods for myofascial release. The myofascial release treatment has several subsets. Now, we're talking 30, 40 years, there are practitioners, and I am one of the trained practitioners, for fascia distortion model, FDM. F as in Frank, D as in door, M as in Mary. And that goes beyond the traditional myofascial principles. There are 6 different models. I won't go into them in detail, but I was asked to travel to train other physicians out of this country. So a few years ago, I went to Belize, and I trained other physicians with a cadre of physical therapists, occupational therapists, other practitioners in this method. We're almost done. So this is the team of us in Belize. The gentleman in the beige jacket with his hands in his pockets, he is the Minister of Health, which is kind of like the director, the medical director for the community. So he learned this fascia distortion model, and again, we have many different practitioners that were there, and we have 2 persons that were local. So my 20 minutes is almost up. I do want to leave you with this information if you're ever interested and wanted to just curiously want to know if you could find a DO. This is one of the websites. And I will share with you our AOA kind of wrap-up video. I think it's a really great way to finalize the formal presentation. So let me see if I can get to that video. 1 second.
We partner in health with those in our care. We are trained in the art of listening and watching, schooled in a tradition of empathy and care for the whole person. We are diligent seekers of a person's complete story. We focus on science and technology, but also consider options to complement pharmaceuticals or surgery. For we see an interrelated unity in all the systems of the body and understand that each helps the others to heal and become healthy in the face of illness. We believe there's more to good health than the absence of pain or disease. Of equal importance is presence of mind, prevention, and recognition of all that is helpful or harmful in a patient's life. We are doctors of osteopathic medicine. We don't see patients, we see people.
Okay, any questions? I think everybody's stumped. I hope not. Okay. Perfect question. So, yes, there are physical therapists who are not only trained in manipulative approaches, but especially the myofascial technique. So when I shared, the question was, are physical therapists using these techniques? So when we traveled to Belize, the gentleman that was in the center, he is a physical therapist. He was the one that directed the training of this fascia distortion model. So yes, physical therapists are alternative, or they're part of our allied health team, and they are typically able to use the techniques as we are. It doesn't restrict us. It's not restricted to us only as physicians. Yes. Yes. When would you seek the services of a DO? So, okay, there are physicians in the community who perform only manipulative therapy, many of whom are just regular primary care physicians. There are some specialist, and what we call osteopathic, OMM, osteopathic manipulative specialist, is a program that you can go into a residency program for. So if you are having pain, if you're having dysfunction, if you have a problem with movement, you could seek out an osteopathic physician to either perform the manipulative therapy temporarily a couple of times, or even possibly maintenance. Or if you're like me, I am a primary care provider, and during my treatment of my patients, if I identify something, they just get that as a perk. Other questions? See, I knew someone was going to ask that. And this is why I love coming here, because everybody has such great, thoughtful questions. So does insurance cover it? So yes, there are procedure codes that the osteopathic physician is supposed to be using. And they're based on the levels. We have 4 levels of treatment from the cervical spine all the way down. And so it is entered as a procedure code. And hopefully the insurance company will honor that. And hopefully the Medicare type will honor it. It depends on how the physician documents during the particular treatment process, but it is supposed to be covered. Yes. Okay, so there's not an overlap between osteopathic and orthopedic physicians are specialists in the surgical treatment of joints. Osteopathic physicians can become orthopedists. So an orthopedist is a specialist, but an osteopathic physician is a physician, a comprehensive physician, regardless of what type of practice type we use, we go into. We are physicians. Not quite sure? Yes. Yes, yes. So I didn't mention it earlier, but in our training, the emphasis is on primary care. So originally, osteopathic physicians were designed to go to these regions where there is no primary care physician or where there's a need for a family physician. So a perfect example I'll give you. I have a cousin who is 10 years before me, an osteopathic physician. And she happened to be from a small town in Texas called Quitman, Texas. She went to osteopathic medical school, and there was, I believe, no physician in her town of 1,010. So Dr. Waddleton, the first Dr. Waddleton, Beverly Waddleton, went to the Texas College of Osteopathic Medicine. She completed the internship and residency program. She went back home, and she became the town doctor, the traditional town doctor. Yes. So primary care is emphasized. Yes. Yes.
Just to interject, my mother had a primary osteopathic doctor who was a member of our church. Nat Armstrong, remember her? She was my mother's doctor until she died.
Wow. Okay. Wow. Yes. So if you've had an injury and you're seeing a chiropractor or have seen a chiropractor and you've seen a physical therapist and you still have pain or dysfunction, should you step out and go to an osteopath? That would be a great opportunity. There, again, is some overlap in what the chiropractor may be doing, but the advantage of the osteopathic physician is, we would be the one to prescribe if we need to prescribe. Let me say one other thing about that now that you brought that up. When I traveled to Belize, the whole idea of that particular fascia distortion model, myofascial treatment, was to train physicians in pain management without using medicine. It doesn't mean that we would never prescribe if we didn't need to prescribe. But I always tease with my patients, and if I don't see them for a while and they come in and they're in severe pain from something, and I say to them, okay, so pain is a motivator. What brought you in today? But pain is also, or I should say, the reason to go is to also identify dysfunction. And what we're able to do is we're able to identify areas that may be getting ready to need manipulation or may need to have some sort of maintenance for something. Another thing that I didn't have a lot of time to bring out from the didactic standpoint is we are trained in how to identify certain areas, what we call viscerosomatic. Viscera basically means internal to the body or the body organs. Perfect example. So if a person comes in and has appendicitis, and true story, I mean, I use the principles, I use all of it day after day, and the person came in and waited for 5 days, was in severe pain. We're talking appendicitis pain, abdominal pain. And I was a little frustrated because I said, well, that's the reason why you go to urgent care or the emergency room. You don't wait because, and I just kind of flippantly said it. I said, suppose you have appendicitis. Before I put my hands and examine you, I would be really upset if this was appendicitis or if this was a ruptured appendicitis because you could die. And sure enough, I'm putting my hands there and I'm like, oh my goodness, I think this is appendicitis. Now, did I have a CT scan? No. And that's the point, is that as a diagnostician, I should be able to get in the ballpark of what is probably happening without only using a CT scan. I would never not use it, but I was able to get in the ballpark, and truly, when I sent the person to the emergency room, that's exactly what was going on. And she couldn't believe that I knew that or I could detect that. And I've had many situations like that where I would say, been led to, this could be this, we have a differential. And with that differential, I better be somewhat close so that at least I can benefit the patient and not waste all of their money doing 50,000 different tests and trying to guess at it. I really have to be pretty clear. And I will say, and I didn't say it earlier, but I'm going to say it now, is that I definitely use prayer before I go in the room. We have a chief complaint when the person tells us what is probably going on. And when I get in there, I am really trying to use full discernment. Even before, I'm sitting, I'm listening, I'm closing my eyes, I'm trying to picture. And even if it's that great fascia thing, I can kind of figure out, oh, wait, this might be fascia. Now I get to use X, Y, and Z, which makes me really excited because I get to treat something without pulling out, like a proverbial prescription pad. I don't want to have to use a prescription. And I can prove to them, hey, we can probably correct this. If we need medicine, we need it. If we need to refer you, we can refer you. If we need to follow up, we will. But I don't want to rely on the technology alone. I want to use my intuition and my skills because it's really a gift. Yeah. Yes. Yes. Yes, it is holistic. Right, the old school family doctor or family practitioner, right, and we've moved away from the term. We used to call them general practitioners, and then family practitioners, now family physicians, now primary care. It's all one and the same. Yes, and I like to say the buck stops with me, because if something's not quite working, then at least we can regroup and go in a different direction based on what might not be appropriate. Right, and that's why I particularly chose family medicine, because I have the benefit of looking at all the aspects and looking at all the different ages and stages as well. And it doesn't mean that these techniques cannot be used on the aging population, also infant, depending on which technique you're looking at. That's correct. Yes.
A while ago, there was a question about the connection between chiropractor and and physical therapy and some overlap. And it was mentioned, well, if you don't perhaps have success with one of those others, what I'm wondering is, but how often might it be the reverse, where if you're having a situation that perhaps maybe a primary physician has identified something, and then they so often say, go to physical therapy, without really investigating even enough on the part of the primary. And sometimes, I know it happened with my husband, you can go to the physical therapy, and they can do more harm without doing more investigation of what the issue is. So I'm wondering if perhaps to go to GO before going to the other.
That's a great question. So, because I've been doing this for a while, this is actually year 31 for me in practicing. In this practice, this has been 10 years. This is year 11 in this particular practice. I pretty well know who I'm referring to. That's number one. So I have a specific group of, if it's a chiropractor and I want the chiropractor to take their time and work with the patient a little bit more, because I do collaborate with them. And if it's a physical therapist, I know which group of physical therapists within our system might be able to address that particular issue, because the physical therapist has access to modalities that I might not use or might not have, like a TENS unit, for instance. But typically, if a person is getting beyond the case of getting better, then it's best to come back to the physician. And in my situation, it's kind of rare that happens, because we communicate regularly. And if a person's not getting better, they'll send me a message. Hey, I don't see where this is getting anywhere. What do you think? And there's a communication, that's open communication between the two areas.
We actually got worse with the physical therapist, worse. And it was because the physical therapist is not a physician. And so there were things that I guess didn't, and this is a good guy who was the physical therapist has been very successful with helping him with another issue years before. But, it's not physicians, and I guess they didn't recognize what was happening. It turned out that it was a surgical correction actually that ended up but one more thing. Are there particular risks with the manipulations that would be something like sign off and saying,
That's a really, really, really good question. So in certain forms of osteoporosis, we definitely would limit things like high velocity, because as you can imagine, it's too quick, it's too forceful, but we can use other methods. If a person has something going on with the spine, and perhaps someone who is not identified, maybe a carotid issue, we would have to be very careful about the quicker motions. I don't believe that it's always necessary to have, a consent, but we do have verbal consent. Anytime I ever use a treatment, there's not necessarily a written consent, but we also have verbal, and we have to document that we've gotten verbal consent.
Any other questions? Ask now. Felecia, I want to thank you. That was most informative. I learned so much today. Thank you so much.